Hey everybody, good morning. I'm Waqas. I'm a fellow University of Chicago. Welcome to our Oncology Data Advisor podcast, where we feature monthly episodes on the intersection of AI and oncology. Today, we're joined by our guest, Dr. Samir Shah, who's the Chief Medical Officer of Qure.ai Technologies and has had over 2 decades of experience as a practicing radiologist. Welcome to the episode, Dr. Shah.
Hey, how are you? Glad to
Hey,
be.
doing well. Going well, going well. Yeah, glad to have you here. Now, we've had Qure.ai as a guest of our podcast last year, but this is the first time you're joining. Just give us a brief refresher about Qure.ai and about your role in the company.
Absolutely. I wasn't here last time, probably because I've been here for about a year and a half now. I'm a radiologist, like you had mentioned, in practice. I've been in practice for about 21 years, all in Pittsburgh, Pennsylvania. Did my training all over the Northeast, grew up in the Northeast, and went to Chicago, did interventional radiology. I started my career as a regular staff radiologist. So I was in private practice and academics. And then I actually, right around the time of the financial crash in 2008, I actually entered the world of teleradiology. And
But,
eventually that became, uh, morphed into large private equity and venture capital owned
mhm,
practices. And I got into the administrative side of medicine. And then over the last 4 or 5 years, I had been involved more and more in implementing AI solutions for large radiology practices. That led me to Cure. Cure had been around for many years. They actually started in 2016,
mhm,
and were just coming into the U.S. And so I met the Cure folks. It was kind of a match made in heaven. They were looking for a CMO, and so it's been a year and a half now. We really had some difficulties in the early days, but you're going to hear
mhm.
a lot about us because things have really turned around since we've been able to get our FDA clearances, and really a great product market fit for health
Yeah.
systems, for radiologists, for oncologists, pulmonologists. So we can
Mhm.
talk more about that too.
Yeah, and there's a lot to cover, but I think today we'll kind of sort of take a deeper dive on some of your recent partnerships and sort of lung cancer screening. So just briefly tell us a little bit about the UH Cleveland partnership and how that came about.
Absolutely. Well, the entire premise, we became big in the tuberculosis space of all things. We
Mhm,
started outside the US in kind
mhm,
of Asia and lower middle income countries
mhm.
where TB is the number one killer
Right.
and infectious disease wise. Obviously,
Oh.
we don't have it here as much in the US, but
Mhm.
because of that, and then with COVID, Cure really became the most globally deployed AI for healthcare. And that's because radiology, even today, Wakas is like
Mhm.
80 to 85% of all the FDA clearances for AI because it's
Yeah.
very natural. It's pixel based, computer vision. And
Right.
then on top of it, plain film is so ubiquitous everywhere that like obviously that's why we are really well suited to it. So we were going everywhere across the world, and AstraZeneca actually said, "Can you guys do something else besides TB? Can you do lung cancer on chest X-ray? Can you find malignant nodules?" And so they asked us to screen 5 million patients, and that's a lot of patients. And we actually just completed that, ahead of schedule. And so, then folks in the US kind of
Mhm.
sit to the hypothesis this could also work in the US.
Yeah.
And because that's
Yeah.
probably because we're so behind on lung cancer as an
Mhm.
entity. Um, we don't really screen the general populace for it. We screen eligible patients at a rate of like 6%. So meaning 94% of eligible patients don't get a CT. And so there
Mhm.
had to be some sort of paradigm shift, and that's our hypothesis. And we went to UH Cleveland and said, what if we used AI on chest x-rays, like outpatient chest x-rays, ER chest x-rays, etc. And radiologists nowadays are so busy and so underwater, as
Mhm.
well as their intellectual focus has shifted from x-ray to CT, that we're
Right.
not looking for nodules on x-ray anymore, right? So,
Mhm.
in my search pattern, nowadays I've got like less than a minute or so to read an
Yeah.
x-ray. And so if the history is trauma, I'm going to look for a rib fracture, a pneumothorax.
Sure.
thorax, mediastinal widening. I'm not looking for that nodule.
Right.
And that's me. I'm 52. The younger radiologists out of training, they haven't even had the time to
Yeah.
develop their search patterns and everything else for nodules, et cetera. So
Mhm.
that was the hypothesis, and it's actually like not not even like a beta hypothesis or like an untested hypothesis. We
Mhm.
know from those 5 million patients globally that we're picking up tons of lung cancers. Um, so that's kind of how this all started. Dr.
Yeah.
Amit Gupta was the
Mhm.
cardiothoracic radiologist. He is a unique person, because he's a real scientific mind. So
Yeah.
in the thoracic radiology world, he's known all over the country. Everybody knows him. He has a
Yeah.
crowd around him at every kind of radiology meeting because he's always thinking outside the box. And then secondly, not only in thoracic, he's kind of become an AI champion. And
Okay.
he's implemented so many different AI solutions at UH Cleveland that he became kind of this natural person that we went to with this. And he immediately got it. He
Yeah.
immediately saw the value of this. And that's how the partnership started.
Awesome. And before we kind of take a deeper dive into some specifics of the performance of the X-ray nodule detection, let's sort of back up a second. You talked about for that 6% statistic that that most patients aren't really getting lung cancer screening with CAT scans, and of course, every PCP, every primary care doc is trained to screen patients for lung cancer with the annual low dose CT scan if they meet sort of baseline requirements about sort of if they smoked a certain number of pack years, and
Right.
then sort of pack years they smoked, and then sort of when they quit smoking. So why do people not get CAT scans for lung cancer screening?
It's a great question.
Yeah.
I mean, even overall statistics wise, I didn't
Mhm.
know much of the data. Um, First of all, the fact that it kills more patients in the US than
Mhm.
breast, colon, and prostate combined. It's a crazy number, right?
Mhm.
So, no question, it's the number one killer in the US and the world. I didn't know that. And then on top of it, the fact that so few patients are actually getting screened, that was
Yeah.
also a surprise to me. And so the etiology behind that is the eligibility requirements, even when they've been relaxed, some
Mhm.
are
Yeah.
still pretty onerous. The number of pack years smoked is pretty high, and then to actually get enrolled into a lung cancer screening program, there are certain hurdles that have to take place.
Yeah.
Certain and one other thing is that we've never been great, especially as technology has kind of come into the health systems, et cetera, and
Mhm.
actually following up on things and making sure
Right.
patients enter certain programs. We're generally a non-compliant society, and so those are the two major factors. And then it's access. Some of the innovative things people have tried is like putting a CT on a bus and like actually going around the community and taking the CT to the patients. And
Right.
that, of course, has really, really helped
Yeah.
uptake. But overall, it's a bad problem. We're just it's a cultural thing too. It's breast and colon. We do a pretty good job as a society. In
Yeah.
fact, anything that we screen for, we're usually at like the 80th percentile. But
Mhm.
for lung cancer, we've been stuck at like
Yeah.
5-6% for a long time.
Yeah, yeah. No, all those reasons really make sense. And so you mentioned the idea of follow up, and maybe sort of getting towards what we're talking about today. When we think about maybe a troubling lung nodule or lesion that's spotted on an X-ray, what's kind of the downstream pathway if it's noted by AI? Who's following up on that? What's the next step? How do we kind of go from there?
A good one. Who's following up on that? If a lung nodule is found in the ER, it
Hmm.
has to make it from the ER doc to the primary care doc to
Hmm.
the lung cancer screening program, and that sounds fairly straightforward, but it's actually really hard, as you know. We lose patients at each step of the way, you know, um, from the ER to the primary care doc, from the primary care doc to the lung cancer screening program. And part of that is, getting them enrolled is a difficult, arduous process.
Hmm.
B, the physicians in general are sometimes confused about the guidelines. You know, do I have to get a regular CT? Do I have to get a low dose
Mhm.
CT? Do I have to do this yearly? Do I have to do this once every 5 years? There's a lot of confusion about it. And really what's happened is like nurse navigators have kind of really helped because the programs that are using a good number of nurse navigators, they're able to follow all the complex things that happen, right? Like biopsy
Mhm.
results, like genetic genomic markers, all the things that happen, so that a lung nodule turns into adenocarcinoma. What's the next step? Bronchoscopy, resection. There's so many steps in our health system. It's such a maze to navigate that I think that it really does contribute to a lot of the fall off that we see.
Got it. And can you share a little bit of sort of data on performance of the X-rays and the technology in terms of detection?
Absolutely.
Yeah.
If we had a nodule detector that
Mhm.
would find anything rounded in an X-ray, we
Yeah.
would drive radiologists crazy.
Yeah.
They would just throw the technology out in the garbage because when you are like so busy like we are, we're just drowning in films.
Right.
It's really changed over my career where now we just kind of go assembly line. Radiology used to be a lifestyle kind of oriented field, and now nobody's out there on the golf course. We're just like trying to get through the mountain of films. And so I think that one part of it is um, if we every nipple shadow, every granuloma, if we bring that to the radiologist's attention, then
Mhm.
it's not a useful technology. So you have to be specific, but you
Right.
also have to be very sensitive. The
Right.
the real goal here is not just to find lung nodules, uh,
Mhm.
it's to find early stage lung cancers. And once a nodule is less than a centimeter,
Mhm.
my own eyes lose sensitivity tremendously. And well, cause there's a lot of hype about AI and everything else, but in general, it's
Mhm.
really, really, really hard to beat a radiologist just because this is what we do, right? We are
Mhm.
very, very attuned to pathology on studies
Mhm.
without overcalling, and we have made that. And I think the difference for Cure is that my CEO and my team in the
Mhm.
early days, all they did was aggregate data.
Right.
And when we did this, the two things we did that was different than anybody. First of all, we had an order of magnitude more studies. We have
Mhm.
50 million X-rays in our trainings data set. And the
Yeah.
geographic diversity of that is crazy. It's from all over the world, all over the US. And then the second thing we did is we didn't rely on a radiology report. You know, inter-reader agreement on nodules is very low. And
Right.
so if you just went by radiology reports, you'd be having a nebulous kind of training set. Instead, we looked at CT proven nodules as our ground truth. So that's actually called super truth. And that's how we based our algorithm on. As a result, we have a highly sensitive, highly specific algorithm that's actually very useful for RADs.
Got it. And I think just kind of expanding on the idea of sensitivity, specificity. I think when people get an X-ray in the emergency department can be for a lot of reasons. They might be coming in with a pneumonia or URI, right? Of course, people can have a metastatic cancer of a separate primary, like a head and neck, so that can cause a lung nodule. So, are you kind of integrating other patient information like smoker status or recent infection? Are those kind of variables you look at to help early detection, or is it just the image?
That is a great point, and that's another thing that as radiologists that like you'd think technology would get better with time. It's actually
Mhm.
gotten worse, right? So like sometimes our history is like some ICD-10 code that we don't know, or it says other, and I'm sure you've seen this as well, like pain, otherwise not specified. That doesn't help. And so what we've done is like, not only do we have computer vision, but we have these great, amazing large language models. And
Mhm.
so Cure has developed our own large language model that
Okay.
actually integrates with the EMR
Mhm.
and pulls the relevant information. So we can
Mhm.
know, is the patient a smoker or not? And as you know, that's a huge difference maker. And all this relevant clinical history is getting
Mhm.
pulled. And it makes it very easy. Not only
Yeah.
mine the EMR, we can actually mine
Mhm.
prior reports. So if there's a prior report, we're looking at a rib fracture, in the ER. But if
Yeah.
it pulls that old report that says, "Hey, by the way, there's a nodule in the right lower lobe,"
Mhm.
that helps the radiologist stay focused on what's important because there's a data avalanche otherwise, and we end up pigeonholing ourselves to just look at the acute problem. It's
Got it. Got it. And that's all really exciting to see the progress you all have made. I know you mentioned sort of early on being involved more with tuberculosis screening and now also doing early stage lung cancer detection. What else can people expect from Qure.ai later this year or other partnerships?
Great question. I think that if you can find a lung nodule
Hmm.
on X-ray, then you should be able to find the same thing on CT, and we've done that. So we have an FDA-approved CT lung nodule identifier, but we took it one step further.
Yeah.
And by the way, what that does is it reduces a lot of tedious work, for radiologists measuring nodules on CTs. Uh, Generally, radiologists don't miss lung cancers on CT. We can miss
Mhm.
like micronodules on CT.
Yeah.
We don't generally miss a lung cancer, right? It's pretty evident to us. And we
Right.
see it all. X-ray, different story. We're missing early stage lung cancers, no question.
Yeah.
So this is a different use case. This is kind of helping radiologists become more efficient and
Yeah.
developing reports that are much more useful for oncologists, pulmonologists, etc. So what we
Mhm.
do is we measure every nodule, but then because we're AI, we can actually find that nodule,
Mhm.
reconstruct the lungs, and then look at every single prior and take those prior studies, find the same nodule in space, and say, what's the doubling time?
Right. Yeah.
Then AI will actually look at the nodule and say, we can take a look at the texture and features, morphologic features of the nodule, and then
Mhm.
predict the malignancy risk by adding that doubling time. And then
Right.
put all this information in the report for the radiologist. Everything is like approved by the radiologist first.
Mhm.
Then it goes into the report in a tabular format, and it's beautiful because you've sped the radiologist up about 50% increase in speed.
Yeah.
At the same time, you've made them like super rads, giving nodule by nodule growth patterns, etc. And I'll
Mhm.
I'll just give you an example of how that is going to change reporting. What we do with PAC systems is sometimes we're so busy that we just compare to the most recent prior.
Yeah.
And because of our nodule follow-up, that might be a CT from 3 months ago.
Right.
And and I know that a nodule's not going to change in 3 months. We're going to say stable. But if you pulled one from 5 years ago, that nodule may have doubled in time. It's a slow growing
Right.
cancer.
Yeah.
And that's the information, the pulmonologists, as radiologists have kind of moved into teleradiology, et cetera,
Right.
you can't come down to the reading room and be like, hey, compare this to
Yeah.
the swan, et cetera. So, we need to do a better job, and that AI is going to help us do that.
Awesome. Thanks for sharing all your insights. And I think it's also really cool to see sort of how you're still a practicing radiologist and sort of involved clinically, but then also kind of integrating that knowledge with sort of, various administrative and now entrepreneurial roles. So congratulations on all the success and thanks for answering all the questions.
I really appreciate the time, and anytime we can explain what we're doing, it's a treat.
Yeah, thanks so much.
All right, take care.
Thank you.